Oh, it's time. Awesome. I'm almost done with this tree and I'm going to see you guys inside in just a minute while you warm up. And then we will start the Christmas presentation because Christmas is for everyone and so is Endodontics. Hi, welcome to this holiday season presentation. I promise you, no boring stuff. So if you and this camera will follow me as I bounce between this clinic and the studio upstairs, we're going to take a very unique journey. A journey which is for everyone. So whether you're an undergrad student, an intern, a fresh pass out, a postgraduate, or even an educator, this presentation is for you. Because Christmas, remember, is for everyone. And of course, like every single time, my opinion does not matter. What matters is evidence, and that is exactly what this entire presentation will be based upon. It always begins with caries. A dentist's nightmare has to begin with caries. Of course, we all know about what happens when you leave behind caries before you start a root canal therapy. Imagine accessing and doing a wonderful job, and then a few months later, you end up with open crown margins. Most root canals fail because caries begins to creep below the good crowns that you've given and once again reinfects the entire root canal system. You cannot afford to leave behind any caries when you start a root canal therapy. So remember, the first step in a root canal treatment is not access opening. It is to remove all the caries, get clean margins, and then think about entering into the root canal space. I want to talk about the simple, deep class 1 caries. Now you must be wondering, why did we waste this holiday trying to talk about class 1 caries? We knew that since BDS first year, right? And I'm an endodontist. Why am I talking about restorative concepts? I'm bringing this up because what you do with that class 1 lesion has a direct bearing on the pulp of the tooth. And this is one concept that has been ignored for far too long. Everyone is in agreement when it comes to excavating the soft decay. That black, brown, bad looking decay, everyone's more than happy to pick up their air rotors and start removing. The problem happens when you reach a point where you get that deep yellow, deep brown, leathery dentine. That is the beginning of all problems and all controversies. In this presentation today, I want to settle that issue once and for all. The first problem has been our belief, our long-standing belief, that this brown leathery dentine is not infected, that it is bacteria-free, and by that logic, it can be and it should be left behind. I see so many posts on Facebook and social media where beautiful indirect restorations have been placed with such brown leathery dentine left behind. And people actually write down there that this is the affected dentine, which is why it was left behind. This concept is now changing, and we will talk about that in a short while from now. This first problem has led to a second problem, which is the idea of fearing the pulpal exposure. The idea that exposing the pulp is a bad thing. So if given a choice between removing caries versus exposing the pulp, Most clinicians avoid the pulpal exposure and they are happier leaving caries behind. The reality is, pulp exposure will not matter, but leaving behind caries, this leathery dentine that we are talking about, will be a complete and utter disaster. And this problem has been compounded over the years by some evidence, some studies which got published, some prominent ones as well. But unfortunately, all these studies put together never quite gave the complete picture. Imagine incomplete evidence with complete misrepresentation and utter misinterpretation, and you have a chaos where the truth, the original concept, is lost forever. Today, let's set things in order. As important as it is to update ourselves when it comes to emerging new literature, literature itself must reevaluate its own outcomes as new methodologies of research emerge. Take the instance of this selective caries removal as an example. The idea of leaving behind that leathery dentine with the assumption that it is bacteria free, or even the idea of leaving behind soft caries only because you fear pulp exposure and because you believe that pulp exposure is something bad, something wrong, something which will decrease the outcome of the final treatment. All that must change. It must change because all these thoughts, all these concepts were based upon some short clinical trials which did not actually account for any histological evidence. We were evaluating things clinically. We never really went down and saw what was actually happening in the pulp by leaving behind caries. And just like that, the idea of bacteria being entombed got there under a good, well done restoration. It's an idea that is very simple to visualize, but nobody actually went down into the pulp, into that dentine, and thought about whether these bacteria were actually being entombed or being killed, or were they very happily prospering there and going towards the pulp and infecting it. Unfortunately, these opinions have been voiced by several people over the last 14 to 16 years, and somehow it is easy to leave behind caries, which is why literature like this is very favorable and very popular. Popularity is not what wins cases, it is evidence that does that. That evidence emerged in July 2020. A histological study done only and only to understand what was happening in the so-called affected dentine. A study which was done only to investigate what was happening to the pulp for real because of the bacteria that you left behind. Bacteria which most previous studies believed were entombed and harmless. Everything that we know about caries removal and its consequence on endodontics will change. Active bacteria, live bacteria, viable bacteria were demonstrated in all tubules as well as in the intertubular dentine, which means the so-called entombed bacteria were thriving in that environment and were sending their byproducts towards the pulp. Looking at this slide alone, we realize that our original concept of leaving behind caries is utterly wrong, because the so-called affected dentine, the leathery dentine, which was supposed to have entombed bacteria, actually has live, living, thriving bacteria, which means to leave this caries behind can be the worst clinical decision anyone ever makes. This was all about the leathery dentine that you leave behind. Let's now talk about what this leathery dentine full of bacteria does to the pulp. Ricucci and others evaluated clinical cases, teeth which were filled leaving behind this dentine, and then these teeth were extracted 9 months later and then sectioned and the pulp was evaluated. The results were startling. Every single tooth evaluated, all the pulps. Let me say that one more time. all the pulps, every single one of them, exhibited inflammation, which meant the caries, which were originally nowhere close to the pulp, were actually affecting the pulp in ways that would eventually lead to irreversible pulpitis. The tooth may not have been symptomatic, as a lot of previous clinical trials did mention, but that does not mean that the degenerative changes in the pulp are not happening. This is something like saying you did a bad root canal, and just because the patient doesn't have pain does not make it right. Exactly like that. Just because the patient may not show symptoms in the short term does not mean that dentine that you left behind, that leathery dentine, that infected dentine, it doesn't mean that it will not have a bad effect on the pulp. Let me give you some clinical evidence for these studies, this latest research that I've spoken to you about. What you see here is a canine where the so-called affected dentine was left behind. Again, remember, it has to be absolutely non-scrapable for it to be really affected. Probably the clinician did not account for this. 6 months later, the patient comes back with a huge swelling on the right side of the face. The tooth was tender on percussion, and all pulp sensibility tests, the cold test, were non-responsive. Which means something had gone drastically wrong with the pulp of the tooth. The moment the pulp was opened, we realized how necrotic the entire system was. There was a frank exudate with necrotic pulpal particles just coming out the moment we irrigated, which meant the caries which was left behind had done its job and the irreversible pulpitis had turned to necrosis. A careful evaluation under the microscope clearly showed the point where the caries had entered into the pulp chamber, which meant the so-called soft leathery dentine, which we thought was affected, was actually pretty infectious, and in the course of the 6 months that the patient was away, that caries had progressed to the pulp chamber. The pulp must have gone into irreversible pulpitis at some point of time, after which it underwent complete necrosis. Let's look at one more clinical example. Let's look at this lower premolar, and we start excavating caries. By the time you reach the third picture, most of you would agree that this is where we stop. This appears to be affected bacteria-free dentine. Let's just leave it there. Let's not expose the pulp. Let's place our calcium hydroxide right there and finish the restoration. For a moment, let me humor you. For a moment, let's stick to this plan. Let's see what would have happened if we decided to cap the pulp at this stage without removing what you see in the third picture. We de-roofed this tooth and exposed the pulp. Let's see what we found inside. The pulp, which should have bled. You know, a healthy pulp bleeds. Even an inflamed pulp would bleed a little more than normal, but it would still bleed. This pulp did not. This pulp was yellow-brown, the typical necrotic pulp. When we tried probing this, the pulp was completely detached from the walls. Remember, a healthy pulp is well attached to the surrounding dentine. A yellow-brown detached pulp is a classic sign of a necrotic pulp. Now imagine what would have happened if we had stuck to our original plan of placing calcium hydroxide after that picture 3. We would essentially be capping a necrotic pulp. The whole idea of using calcium hydroxide is so that we can maintain the pulp in a state of viability. However, in this case, as we saw, the so-called affected dentine, or what we assumed was bacteria-free affected dentine, actually caused the pulp to undergo the degenerative changes and actually fall into necrosis. Which means by capping an already necrotic pulp, we were not doing anything scientific or anything which was medically right. Our original diagnosis Our original assumption that the leathery dentine we saw in picture 3 was in fact something we could leave behind was completely wrong. We can no longer talk in terms of selective caries excavation. There is enough evidence to tell us caries has to be removed non-selectively. Let me now show you what this whole non-selective caries excavation is all about. Every single restoration has to be planned like that. Take a look at this case. Everyone is tempted to stop right there at the lower picture, assuming it is affected dentine. From what we have just realized, the clinical way of executing it is very simple. Take a sharp spoon excavator. I think let me say the word sharp one more time. Take a sharp spoon excavator and start excavating. Till the time you can scrape off the dentine, keep doing it. Do not look at the color and assume this is going to be affected dentine. Keep scraping the dentine till the time you cannot scrape anymore. You will reach a point where your sharpest spoon excavator will not give you anything when you scrape hard. This is the actual affected dentine. This is where you actually stop. You may have even reached the sclerotic dentine if you are really close to the pulp chamber. Remember, we are removing caries non-selectively. We are not selectively biased towards a leathery dentine. Everything that can be scraped should be scraped away. Once you reach the adequate depth, you will need to protect the pulp. The material of choice for me is MTA. It is not wrong to use different other forms of calcium hydroxide, but when it comes to the results, MTA is definitely better. Thank God I'm a dentist. It trains me to mix a lot of materials, which also means I can mix a very tasty Christmas cake batter. Why am I mixing a Christmas cake batter here in the middle of this presentation? It's simply because this Christmas batter is going to teach us a very important lesson in endodontics. Let me just keep this here before I break it. What we've realized so far is that MTA is a very important thing when it comes to our procedures. What we've realized so far is that calcium hydroxide is a thing of the past. MTA has overtaken almost every role that calcium hydroxide once used to dominate. Which means MTA is something that every single clinician needs to know about. I get a lot of videos, a lot of pictures on WhatsApp by clinicians from all over the country, which actually tell me, you know what doc, we are not able to get MTA right. MTA doesn't seem to be working in our hands. The key to good MTA procedures is its consistency. Just the way a perfect consistency is needed for the perfect Christmas cake, the perfect consistency of MTA is required for its success. If this batter is too thick, the cake won't fluff up. If the batter is too thin, it'll just flow and it won't really work. Just like this Christmas cake, the perfect consistency is the key. Let's switch over to the microscope. Let's switch over to that camera and let me show you how MTA is mixed and what exactly is the perfect right consistency. I will just take this here. If you could shift the camera and let's get this onto the scope. Perfect. And I'm going to adjust my chair. And once I'm all set with this, we'll switch over to the camera here and let me show you under magnification what mixing MTA is all about. So I would want to split my MTA, whatever quantity I'm using, into two halves. so that if I mess up the consistency the first time, I do have something to mix that fluid MTA with. I will begin by mixing the powder with the liquid. What I've achieved here is too thin, it's too fluid. I cannot possibly load this MTA onto my MTA carrier, which is where I will mix more powder with it. The idea is to get a consistency known as the wet sand consistency. Exactly like the sand you see on construction sites, that's the consistency that I'm looking at. It shouldn't be flaky, it shouldn't be fluid, it should be right in between, the wet sand consistency. Wet sand is very easy to load onto MTA carriers. What you see here is still flaky. The MTA is not coalesced into each other. I might want to add just a little bit of fluid here, not too much. Let's see what we've got here. And right there, what you have now is the perfect wet sand consistency. The MTA is fused into each other, the particles. It's not flaking away like biscuit chips. It's not fluid, it's not runny. And when I load this MTA into the MTA carrier, it's really simple to do that. It comes out in the same consistency in which it was mixed. A flaky MTA would have spread all over this sheet. A fluid MTA would not have been possible to load that here into the carrier. I'm going to show you some clinical videos now. You'll be able to see the difference between flaky MTA and the perfect MTA. Now you know what you need for the perfect successful MTA procedure. Alrighty, so we're done here. I'm going to go upstairs, put this delicious cake into the oven, and then I will meet you at the studio and let's take the rest of this party, this presentation, upstairs. See you in a minute. Oh, and while I walk up the stairs to the studio, let me play one video for you to finally explain in a gist what non-selective caries excavation is all about. Catch you. It's so good to be back with all of you, and this time beaming here from the studio. We will pick up this presentation exactly where we left it. We've been talking about non-selective caries excavation, and we discussed how everything which is scrapable has to go. Throughout that discussion, I kept saying, do not fear pulpal exposure. This sounds exactly opposite to what we've been taught all this while. We've been trained hard to believe that pulpal exposure is something which is not forgivable. We have been trained to believe that pulpal exposure is something that we have to avoid. Why has this thought process completely changed? This was because earlier on, the procedures of vital pulp therapy, which included direct pulp capping, partial and complete pulpotomies, were based upon very loose clinical criteria. They did not quite have a histological basis to it. For years together, nobody really histologically evaluated the pulp and tried to figure out what was really happening when vital pulp therapy is done. Which is why when you look at the older clinical trials in the last 10 to 15 years, we realize most of them have placed the success rate of vital pulp therapy procedures to be in the late 30s or 40% only. The predictability of these procedures is considered to be really low, which is why a number of societies all over the world have limited the success, have limited the recommendation of these procedures. However, with new evolving evidence, new histological evidence, that entire thought process has completely changed. This new evidence for the first time actually evaluated what was happening inside the pulp. And they realized that there is a very specific series or sequence of changes that happen with the pulp the moment caries touches it. For the first time, we started realizing, and this is not new, this histological idea of vital pulp therapy has been around for the last 5 or 6 years. It has gained so much traction that we are now beginning to rethink or reassess or reevaluate our ideas of what is reversible and what is irreversible pulpitis. A large number of treatment criteria are being modified based upon these histological findings in the last 5 years. To sum them up for you, what we've learned in the last 5 years is that once caries touches the pulp, the entire pulp does not become infected in one go. There is a zone of necrosis at the point of caries entry. This is followed by a zone of inflammation, which is followed by normal, healthy, viable pulp. Which means if you can remove this necrotic and inflamed pulp and reach the healthy, viable pulp, you actually can preserve that pulp. You do not need to resect it. Which means you don't have to do a pulpectomy or a root canal therapy every single time the pulp gets exposed. You can actually get away with more conservative procedures like direct pulp therapies or even partial and complete pulpotomies. These were procedures which were relatively unthinkable a few years back, especially when the tooth was showing all the signs of the traditional irreversible pulpitis. We teach this in EEducation in a very simple way, which is exactly the whole idea of E is based upon making it really simple for everyone. Think of it like the way leaves turn from green to brown in the autumn season. There's a whole video series about vital pulp therapy and all of this. I hope you will enjoy it as much as I enjoyed making it, but let me sum that up for you. Just the way the leaf does not turn from green to brown overnight. First the tip turns brown. This is followed by a transition zone, followed by the rest of the leaf being green. That is exactly how necrosis spreads slowly from the tip of the pulp all the way down throughout its length and breadth. Which means at different stages, the pulp is undergoing necrosis in portions. Vital pulp therapy is based on the fact to identify these infected necrotic portions, remove them, and leave the rest of the healthy pulp absolutely untouched. There are certain very specific criteria which have to be met.
The pulp has to be viable, the bleeding has to be controlled, the pulp has to be attached, and a couple of other criteria which are very simple to follow under magnification. But if you can follow them, the latest clinical trials have placed the success of these procedures to be as high as 92% and survival rates of over 5 years. Which means vital pulp therapy is the future. Actually, no. I think vital pulp therapy is the present. We just need to stop thinking in our traditional ways and embrace the new evidence that is presented before us. I wish we had more time to discuss this. There is a whole series on EEducation. Do check that out for the details on vital pulp therapy. Let me show you some of my clinical cases and experiences with vital pulp therapy. That's an upper first molar which was exposed under caries, and you can see the red hue of the pulp very clearly exposed. We met all the criteria that are required for direct pulp capping and placed MTA. We've been following this tooth up for the last 3 years. The tooth is responding under perfectly normal conditions to the cold test. The tooth is absolutely asymptomatic. There are no radiographic changes and the tooth is completely functional. In another instance, a lower second molar which developed irreversible pulpitis because of crack lines propagating into the pulp space. And yes, that is another topic that I wish we had more time to discuss, but perhaps another day. So in this case, the lower second molar developed irreversible pulpitis. The tooth met all the latest criteria based upon histology for a pulpotomy, and we decided to go for a full pulpotomy instead of a root canal. 2 years later, the periapical lesion, which was very clearly visible in the preoperative X-ray, had completely healed. The pulp responds normally. It is still alive, it is still vital, and completely functional under normal occlusal load. This is the beauty of vital pulp therapy. If done correctly, it is an extremely predictable and an extremely successful procedure. It is more conservative in every respect, and it is much simpler to do than a traditional complete non-surgical root canal therapy. To show you the beauty of vital pulp therapy, here's a picture from one of the cases, and this entire case is there on EEducation.in. The moment we opened the pulp space, that is, we de-roofed the chamber, you can still see the caries there. The caries has not been completely removed. But the moment the first de-roofing was done, you start seeing areas of the pulp which are healthy. In transition, there are areas which are necrotic, and then there are other patches which are healthy. You can actually differentiate the state of the health of the pulp clinically under a microscope if you follow the histological criteria that have emerged after the latest research. In another video, you can see how the pulp is completely controlled, the bleeding is completely controlled, and the pulp is absolutely attached to the walls of the dentine. This is healthy, viable pulp. That's a full pulpotomy on a lower molar with irreversible pulpitis. Our ideas are changing. Let me be very clear. I do not want you to randomly go out there and start doing direct pulp caps and pulpotomies without knowing these criteria. If you follow the old school and do these procedures randomly, you will not get the success. It is only after understanding the newer criteria can you predictably perform these procedures. You must be wondering, I'm talking about autumn leaves when I'm talking about a complex topic like vital pulp therapy. What is really going on here? I spoke about mixing a Christmas cake while talking about something as serious as mineral trioxide aggregate. Well, that is what we've done with EEducation.in. It's an attempt that completely redefines the narrative of how endodontics should be taught. Endodontics was not meant to be taught in a classroom. Let me show you a quick video and help you understand what exactly is E all about. I have a feeling all of you will like it.
Endodontics was not meant to be taught in a classroom.
Imagine the pulp chamber floor to be like this manicured garden here. Those two large water bodies that you see are like the main canals. If you observe, there is a tract of brown which is connecting the two main canals. This tract is actually visible even inside the tooth. This tract of brown is known as the dentinal map.
My opinion does not matter. What matters, and only thing that matters, is evidence. Because COVID-19 is evolving really fast, and EEducation will make sure you are never left behind. This is going to be a trip like no other. My bags are packed. Are you coming with me?
One of the criterias, besides the histological criteria, is that all these procedures must be done under complete isolation. Which means you cannot have the tooth swimming in a pool of saliva, contaminating your exposed pulp, and expect to get a 92% success. Rubber dam isolation is absolutely necessary. Speaking about rubber dams, I see a lot of people have started using them. For some cases, I stress on the fact that a rubber dam must be used for all cases. Even something as simple as a cervical caries or a cervical lesion, a non-carious cervical lesion, should be restored under rubber dam. And it's not just about maintaining good material quality. It's about something else. Remember, I told you I want to talk about endodontics, but also about how the simple basic things you do every day influence endodontics. I've seen so many cervical fillings to be over-contoured. They lead to gingival inflammation, which leads to food lodgement, which leads to a new wave of caries underneath these cervical restorations. And this secondary decay eventually reaches the pulpal space and you end up requiring to do a root canal therapy. That has to stop. That has to change. When we talk about restoring cervical caries, I suggest that you use a gingival retraction cord first. This stops any inflow of the gingival crevicular fluid, and after that you should use a rubber dam. The best way to restore these lesions is to use a clamp which actually retracts the tissue. Tissue retracting clamps are very commonly available and follow the same principles of use like everyday other rubber dam clamps. Once you've done that, you will be able to define and see the extent and margin of your cervical lesion. The restorative material that you will place will then be absolutely flush with the tooth. There will be no over contouring. You will be able to completely adapt the material, and since there will be no saliva or gingival crevicular fluid, the material will actually adapt and not leave behind a space where caries can start again. Let me show you a clinical case where the pulp was exposed by a distal caries, but when we opened the pulp up, we found the necrosis to be far deeper than could be explained by the distal caries alone. When we excavated further and went under magnification, we started seeing that there was a point of entry from the cervical area. Later on, we realized that a cervical caries had penetrated all the way into the pulpal space. So the tooth was actually attacked from two sides, from the distal as well as from the cervical. Take another example. A lower canine had a cervical old restoration. The moment we started removing the old restoration, we could very clearly see the secondary decay present below the cervical restoration. This usually happens only because when the restoration was placed for the first time, adequate control of saliva and gingival crevicular fluid probably was not achieved, which opened the floodgates for percolation to happen and secondary decay to restart. That's one possibility. The other possibility was that maybe the previous clinician did not do non-selective removal. Maybe he left some caries behind. Maybe he thought that caries was affected dentine, while in reality it was very much scrapable. And that caries spread on, and as we removed the restoration, we could very clearly see how this caries had reached the pulpal space of the tooth. Even in this case, by using a tissue retracting clamp, we were very successfully able to isolate the entire margin of the tooth, remove all the caries, and predictably restore it to good health. The idea of rubber dam is not just an idea in theory. It actually decides the fate and predictability of your procedures. You irrigate better, you can see better, you retract better, you can focus better. Always use a rubber dam. And trust me, the longest time it takes in a rubber dam is to convince a dentist to use it. Somehow over the years, rubber dam has been made to be something very difficult, something that advanced learners can understand. At EEducation.in, we've created a very special series. It's a series of 7 episodes plus some other bonus clips, which actually makes the whole idea of rubber dam very simple. Let me show you a little trailer about rubber dam and how we teach it. Let us try and see how a rubber dam clamp fits and how we can relate it with something very exciting in aviation. A rubber dam clamp really looks a lot like a helicopter. The landing gear of a helicopter and the jaws and prongs of a rubber dam clamp actually look a lot similar to each other. And interestingly, as we will just see, the motion of landing of the helicopter is exactly how a rubber dam clamp lands and fixes itself onto the tooth. Look at the helicopter pilot bringing its landing gear almost parallel to the ground. Similarly, we position the jaws and prongs of the rubber dam clamp parallel to the occlusal surface. Once positioned parallel to the occlusal surface, we now open the clamp and then gently lower it towards the neck of the tooth and then remove the rubber dam forceps. We have a lot of fun while we shoot for E. The whole cast and crew and cameras and lights, it's just like shooting for a movie. And especially the outdoor locations. We don't like shooting it in a studio, we don't like doing blackboard teaching. Endodontic education for me, as a speaker, as a teacher, is not about blackboard teaching. It's not about me trying to explain a concept. It shouldn't be complex. I believe the most difficult concepts can be broken down into not just simple but also fun ways to learn, which is exactly what we try to do with every single episode of E. Yes, we don't call them lectures, we call them episodes, because watching an episode of E is like just taking your remote, switching on the television, and maybe watching your favorite show there. We believe the idea of binge watching doesn't just apply to these online platforms, I mean the movie platforms. It should also apply to dental education. And we believe with E, that is exactly what we've done. Which is exactly why I wanted this webinar to not be a webinar. Which is exactly why I promised you no boring stuff. Because we believe everything should be done in the way E has been shot. Which is precisely what we've tried to do here. I did choose these very different unconventional topics because I know nobody talks about them, but somebody has to. It can't always be about access and working length and obturation. It has to be about the things that really matter. Now think back. How many of you felt I did everything right in my restoration, but the patient still came back with pain? Now start thinking, was your caries excavation selective or non-selective? Is it possible you might have left behind some caries? Now you know the criteria for it. For a lot of advanced clinicians, postgraduate students, I keep getting these calls which say, we tried to do vital pulp therapy, but it didn't work out. I think it's a bad procedure. Now that you know the criteria have changed, perhaps you will be able to watch those criteria on E, and then when you perform your procedure, your results will be different. That is what E is all about. It's about change, but then it's not all fun. It has to do with a lot of evidence. Every single episode of E is based upon pure evidence. It is backed by solid literature. And as the literature changes, our episodes update themselves. In fact, we even make episodes based upon the problems that our viewers face. So write to us and we will make a series to solve your problems. Let's take this ahead. Before we wrap this up, let me give you some other tips and tricks. One thing is about finding canals. And we shot this episode of Finding Canals all outdoors, and we tried to relate how the dentinal map inside the tooth actually looks like the garden that you see in this picture. But other than that, I do recommend using a CBCT. A CBCT often shows you things which a two-dimensional X-ray simply cannot. Take an example where this clinician found the MB1, found the MB2, but the pain wouldn't go away. He kept taking multiple X-rays and realized that there was nothing wrong with the tooth. I asked for a CBCT, and I prefer looking at my CBCTs with some contrast as well, so that my eyes are not just accustomed to the black and white. The moment you change the whole color palette, you may actually be able to see things slightly better. And very clearly on the CBCT, we could see an MB3 canal. The incidence of these canals is not very high, especially in the Indian population, but they're still there. Which means if they're there, you need to find them, prepare them. And in this particular case, the MB3 was an absolutely separate canal. That's the importance of CBCT. If it is available in your city, do speak to your radiologist and make sure you're on the same page so that you can predictably find out these missing anatomies and your patients can go back happy. Another quick tip that I will tell you is the use of apex locators. For the longest time, I've heard people say, I think let me switch from a film X-ray to an RVG for working length. A lot of times I've heard people say, nah, I have a very good quality RVG. I don't need an apex locator. I've heard endodontic residents and even endodontic practitioners tell me I use an apex locator for some of my cases. For the others, I just rely upon the X-ray. Well, let me tell you, a two-dimensional X-ray shows you nothing. This is not an exaggeration. It absolutely tells you nothing, because the idea of working length is not a radiological idea. It is a histological idea. You need to go down to what is known as the apical constriction or the minor diameter. Again, I wish we had more time to talk about this, but there is a whole episode. Now, there's a whole series on working length on E. Do check that out. But the idea of working length is about reaching the apical constriction. The apical constriction cannot be seen on a radiograph, which means you need a device which can actually predictably find out where this apical constriction is, and that device is the apex locator. There is mounting evidence that will show you that you can go wrong by almost 1.6 millimeters sometimes if you are not using the electronic apex locator. And there is no other way you can find out clinically where the apical constriction is. Which is why you need to have an apex locator for every canal, for every case, not just for some cases. Let me show you how we talk about a serious concept like this on EEducation. It's one of my favorite trailers for E. Let's take a look.
Good evening, ladies and gentlemen. This is your captain speaking. Please close your books and look out of the window. The next lesson in Endodontics is out there. Let us draw a rather interesting comparison. Imagine the sun to be the source of the X-ray. The curved wing is like your curved root, and the runway becomes your film or your sensor. The shadow of the wing that you see is like the IOPA image. See what happens when the plane turns, which means the X-ray shifts from a straight to a mesial or a distal shift. The curvature of the curved root is lost on the image, and the canal appears to be a straighter canal as compared to the actual curvature that exists. As the angle shifts, there may even be a shortening of the radiograph.
And that's the way we do it. EEducation is for everyone. You could be an undergrad, a student, an intern, a new clinician, a seasoned clinician, a postgraduate resident, or even an endodontic educator. E has something for everyone. From the most basic things all the way to the latest cutting-edge research, we try to break it down to the simplest yet the most evidence-based way to explain it. Do check out www.eeducation.in. You can register for free using your email address, watch some of our free content, and then subscribe as you like it. Well, I hope you had fun both with this trailer as well as this very different kind of a presentation that we've attempted here, the EEducation way. I think that's all the time we have for today. I really wish we could have done more with all of you here. Also, my cake. Remember that batter I was mixing in the clinic? Yeah, that one. My cake is all ready, and let me quickly munch this. Just like the MTA. Perfect. Let me finish this up, and I will catch you guys live for a Q&A session. And let's talk about all the stuff that we've discussed. And any question that you have, let's take it there. Thank you so much, guys, for being such a wonderful audience. Let me see you for the Q&A session.